Okay. Hi, I'm Dr. Youssef. I'm going to show you some tricks that we learned through the years of doing cataract surgery. One of the best tricks I ever learned in cataract is the use of the J-cannula for cortical cleanup. J-cannula is simply a J-shaped cannula. It's a 27 gauge cannula. We put it on a 10 cc syringe filled with BSS, whatever solution you're using during your phaco, so you just fill it from the infusion of the phaco machine. We use it to clean up the cortex after finishing the phaco and before the implanting the lens, so that this way we will not do any irrigation aspiration before we implant the lens. This will protect the capsule from being torn by the phaco tip, by the IA tip. And the good thing is that it can clean up even the areas that you don't see, like the fornices of the capsule that you don't see, that's behind the iris, and so it decreases significantly the amount of PCO that you would get. And it can actually irrigate the smallest pieces of cells and cortex that you cannot actually clean by doing the irrigation aspiration because you're afraid of capturing the capsule. And it's done very, very efficiently in a very short period of time. It takes about maybe anywhere 10 to 15 seconds to get done with the cortical cleanup, and takes 10 mLs of fluid. Some doctors were afraid of the amount of turbulence that happens in the eye. There is some turbulence, but in the videos I will show you, you'll find that, for example, air bubbles or viscoelastic material stuck to the back of the cornea did not move during the irrigation aspiration. So the fluid just cleans up the cortical material and just washes out of the wound along which the cannula is introduced. Some tricks that you have to be careful when you're going to use the J-cannula is that you have to very strongly put it on the lure lock, because it happens once that the nurse did not actually fit it very well and it flew out of the cannula, and you actually use a lot of pressure when you're using it. So you have to make sure that it is stuck very well to the cannula, otherwise it will fly like a bullet. So for example, I'll put it this way, just put a little bit, and I'll do a little bit of pressure, it's going to fly away. It just flew like a bullet. I'm just going to be back to get the cannula. Here we go. Actually, with this little pressure, it just went right across the room, the surgery room. So it went about 10 feet hitting the wall. So you don't want to do that. You have to make sure that this is really, really stuck, and you have to check it out. And before I put it in the eye, I learned to actually press as much as I can to make sure that this is not happening. Okay. When you go inside, I like to leave a very small opening in the cortical material so that I can put the J-cannula through that. So I put it in and start irrigating on the bottom of the capsule from across the wound towards the wound. First in the posterior capsule, and then I go through this way to the fornix this way, irrigating the capsular material from this side, and then going to the other side, irrigating the capsular material from the other side. And they're all coming out through this one. One trick you have to be careful with is that you have to make sure that this cannula is underneath the anterior capsule, because if you don't, you're actually going to be irrigating into the vitreous cavity or into the fornix, into the sulcus. So when you rotate it downwards, you're going to be right in the vitreous cavity. So one of the most important precaution you should learn is that you make sure that the tip of this cannula is underneath the anterior capsule. So you're going like this, okay, and irrigating like this, not like this, okay, because it's going to be the vitreous cavity. So usually it takes about maybe less than 10 mLs to do the efficient cortical cleanup. Okay, and if you need, you can refill. Just take the plunger out. You fill it from the irrigation part of the phaco machine and just put it back again. Rarely I need that, but sometimes we need it. The good thing is that you can do that even in small pupils, so you don't have to see where you're irrigating. But again, the precaution is to make sure that this tip is underneath the anterior capsule. So if in doubt, you're going to put it to touch the posterior capsule in the middle where you can see it, and then slide it over that to be in the fornix. So this way you make sure you are in the fornix. Okay, that's the J-cannual I'm using. There's for many companies, that's from Alcon, and it's 27 gauge. Okay, and that's the order if you want to order that. It's they come from different companies in different configuration, but that's the one I'm using. So again, the most important precaution is to make sure that your tip is where it should be. About the power, you will be injecting the hardest you can, and that's very important to be effective. If you irrigate slowly, you will not be able to clean it up. So you have to irrigate really hard to be able. And again, you have to make sure that the tip is really tight on the glue lock. So that's about it for the J-cannual. The second trick learned through the years, which decreases the amount of endophthalmitis you get. I got one case in the past 4,600. That's before we started to use the Avelox. This is the Avelox. It's just antibiotic ready for use for IV, and it's oxyflex and fourth generation quinolone. We take it into this 20 cc cannula, the syringe, and we give 1 cc per case. At the end of the case, I'll hydrate the wound to close the wound and make sure that you have much more than MIC, minimum inhibitory concentration of antibiotic into the anterior chamber at the time you need it, and it's going to stay in the wound and protect you from endophthalmitis for the coming few. I'm not sure the duration, but it's maybe a day or two. Make sure that it's covered because it stays in the cornea. You can see it first and second day into the cornea. It appears like a wound edema. The optometrists, when they see it, they say it's a wound edema. It's still the Avelox stain there, which I like because it protects it. Since I started to use that for the past 3,000 cases, there's 0 cases of endophthalmitis. That's really good. Some of the tricks, we try to lay out the room to be in, so that we don't move the foot switches during the day. So I book all day right eyes, all day left eyes, and we don't move anything during the case, during the day. One other thing is that instead of connecting the patient to oxygen, for each patient has a mask and stuff, I just connect that what we call oxyflex. It comes from Stryker, and I just stick it to the microscope, so I don't need to move it from one stretcher to the other. And actually I connect it to suction rather than oxygen, because actually you just need to remove the carbon dioxide from underneath the grapes, and that's connected to suction, just suction. There's no oxygen there. And the patient, the pulse oximetry didn't make any difference from putting the oxygen or putting the suction, so it works as good. So it's just like lifting the grapes up and creating that tent without needing to put oxygen. So we save a ton of oxygen every day by doing that. One other thing that I learned through the years, sometimes you get
Le code jaune est annulé. Code yellow is over. Code jaune est annulé. Code yellow is canceled.
So sometimes you get fogging of the eyepieces during the procedure because the mask, for example, is leaking, or the room is too hot and humid, so the eyepieces start to fog. So the best trick I learned through the years is to actually stick a suction tube. It's too hard. Okay, so I stick a suction tube like that over the eyepieces and just put it on maybe, what is it, about 30 or 40, to just remove all the the perspiration just wash out all the perspiration coming from you. So it doesn't fog the microscope. So in the worst cases, when the room is hot or humid, the AC is not working very well, the mask is leaking, just put that there. It's going to take care of the fogging of the eyepieces. So that's about it for now. Okay, thanks.